What's going on, everyone? Welcome back to my channel. In this video we'll be going through my first reports for my OSCEs, where I failed. I am working on an OSCE app. Yep, so I've been doing OSCEs now for a while. After doing this resit, there's an app that I'm trying to make that should hopefully help you to work through your differentials, your investigations, and your managements for conditions that come up on the UK MLA exam. And I think it'll be a different way to study than just doing practice questions and like SBAs. By hopefully working through cases, I think it helps you to get better at formulating differentials, requesting the right investigations, requesting the right management. So I'm working on this. If you would like to be part of the first people that see this app and get access to this app, then please add your email. There'll be a link down below, so just add your email so you'll be notified when this app is available, and then you can try it out and just let me know what you think. We have a very comprehensive document here, and this also compares your scores by different domains, as well as comparing your scores with other students in your year that took the same exam, and just sees how well that you did against them. So this may be a bit of a long video, but I'll try and shorten it and see how to make this video quicker. But I hopefully this should be useful for any of you that are going through OSCEs, especially if you're in final year in the UK. This is a new format that started this year. Normally we used to have 10 stations, but this year it was the first year that we had 12 stations, and now earlier years also having 12 stations as well. And yeah, hopefully it should help you. I guess now looking back after I've passed my resit, I'll also go through it in like a separate video going through my resit as well, but hopefully this should help you. So yeah, let's start by reading this. This report details your results from the recent CCA, divided into the total CCA score, number of stations, passes, individual station scores and results, scores and domain themes, detailed station results, including numerical feedback, and individual and cohort written feedback. Okay, and in all charts, the distribution of scores in the cohort is shown, labeled with percentages where these add value, and your position within this is highlighted. When reviewing these, please note that domain scores are not weighted equally in stations, nor across the CCA. Domains are weighted in accordance with their importance in their tasks being assessed, which in turn are balanced to sample appropriately from the MBBS curriculum. This feedback initiative remains supplementary to the official feedback report, and we hope it adds value. Please do take a few minutes to let us know your thoughts by following the survey, blah 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 blah. Anyway, so yeah, here was my score. Looking back now, it's just honestly crazy. I thank God I was able to pass on the resit, because on this day, I guess just to go through a bit of what my mindset was when I was having this test. Normally my mindset to revising in med school is I start from early. I start from like the first day. I try and get OSCE practice going. This was the first exam I've ever failed in medical school, but I think it definitely was humbling. It made me realize that I was relying too much on my own strength. I wasn't focusing as much as I was on God and my faith, and that was definitely something I changed this time around. And also a lot of medical school exams, from what I've realized, is you definitely just need to have a lot of confidence, especially in the OSCEs. You need to have a lot of confidence, even fake confidence if that's needed. I don't feel that I had as much confidence as I normally would have in my examinations, but yeah, that's also something that really changed surprisingly in my resit. Even though I was so nervous, I was so afraid of having to retake the year, confidence was definitely something that I had a lot more on the resit. Okay, so if we can look through here already, we can see my score over here, 58.5, the number of stations passed. You need 8 to pass, and also the results. And you see, like the year actually did really well. Like looking at the score, most people, just under half got got 12 stations. Over half, 41 plus 28, they got over. They more than passed. Like this was like the cutoff from 8, 9, 10, 11. So very few people failed. So I don't want to sit here and say that the exam was unfair or anything like that. I know I made mistakes, I messed up, the things I said wasn't right, and hopefully we can correct those things and go through them here today. I've gone through this score a lot with different people in the lead up to my resits, so let's read it again. So let's have a look at a summary of my stations. So these are all the 12 stations that we had and my scores for each one. So we can see like my score for the first one, the primary care consultation involving difficult news. This was Breaking Bad News. I failed. We see a few of them that I passed here. Some of them I did quite well on, like the peds one here, obstetrics and gynecology. But you can pause and have a look through each of these stations and the overall themes if you want to. Yeah, this one was horrible. Discussing the medical procedure, and the crazy thing is, I didn't even think I failed that one. Like, I generally thought it was good when I did the exam. But let's get started, and let's have a summary by domain. So in applied knowledge, my score is 58%, which was below the cohort median. Clin skills was below the cohort median. Com skills was low. Data interpretation was low. Professionalism wasn't too far off, but it was low. Management was, it was a bit lower than the median. Okay, so the station scores in detail. So let's go through the primary care in Vogelen, breaking bad news. Yeah, this one. Let's go through the feedback. So it says that I introduced myself as a medical student, which is something that I didn't realize was that deep. I guess on a lot of the stations they will tell you that you are a doctor working in so and so and so, but I introed myself as a medical student because in my mind I'm still a medical student until I graduate. But obviously I guess they really want you to see yourself as a doctor, which is something that I took on board in the reset. They said the medical history was quite rapid and could have included a more open questions, and it took a bit too long to get to the results, even though the patient mentioned several times he was eager to hear the test results. Steroid and testosterone use was not elicited, a lot of information was given quickly, understanding could have been checked more frequently, there was no need to list all the blood tests, it was too much jargon, and lifestyle modifications should have been focused on more, this wasn't covered. So just quickly, in terms of what I thought I could have done better, I was definitely speaking too fast. I finished the station too early, because from all my previous practice in medical school and the sessions that they've hosted for us, the main aim was to break bad news, to use the spikes mnemonic, which you can see on Geeky Medics, which stand for things like settings, perception, invitation. It just shows you a structure to break bad news, which I thought I followed, but I didn't realize, like, on the day of this exam, a lot of the information they wanted as well was in the history. So normally in stations before, once you break bad news, the patients will be quite distraught, sad, cry for a lot of the station, which would take up time, and you just have to manage that and manage their plan going forward. So let's say you're breaking bad news of cancer, you would tell them about things like cancer support specialist nurses, the fact that they'll be followed up by a specialist in, like, let's say a respiratory specialist if they have lung cancer, that they'll have more intensive scans, that they will be discussed in a multidisciplinary team. Those were like the main things you say. I would still say that in this station, but you also had to, there was a lot of information that was hidden in the history, which they said I was unable to elicit steroid and testosterone. If I was to be a bit biased, I don't really feel like my patient was as forthcoming. I felt like he was hiding things from me. But then from speaking to other patients, they said that maybe he wasn't able to give me the information because I wasn't as like my rapport wasn't suited to the station. So in different stations, especially the longer stations and stations like this, really try and make sure that the way your rapport is suited to that station. So if it's a breaking bad news station, you should be matching the pace of the patients. Slow, somber, the mood shouldn't be upbeat. If you speak fast like me, you need to slow that all the way down. And as well as giving information, give it in even smaller chunks. Treat it like a communication station, but bring back the amount of times that you speak. You should really be making sure to listen and leave room for silence as well. But listen to the patients, give them room to respond, give them room to let you know what they're thinking, just really create that environment for them to open up and to give you this information, which is something I wish I did. Then they gave me the feedback here. I'm not sure if I should read this for everyone because this video is going to be really long. But it just kind of gives you, I guess maybe for the ones I failed I can read it. It says, like, most students demonstrated warmth and professionalism in this sensitive consultation, showing empathy and building rapport through effective non-verbal communication. Stronger performances explore the patient's emotional response early, give appropriate warning shots, and pause meaningfully after delivering the news. While explanations of results were generally clear, marks were often lost when students used overly technical language. That's something I feel I could have worked on as well, by not using as much jargon in what I was speaking. Especially for column stations, you really need to get rid of all the jargon. When you're explaining back to the examiner, feel free to use all the jargon you want. In fact, I implore you to. But when you're speaking to patients, you really need to try and bring your language down to be something that can be easily understood, something that you could explain to your friends and family. Some students introduce specialist treatments like IVF prematurely or fail to check understanding before proceeding. High-performing candidates tailor their communication well, explore the psychosocial impact, and address lifestyle and relation factors, including the patient's reluctance to tell his partner. Some missed cues such as steroid use or reassure too quickly without clarifying contributory factors. To improve, aim to listen to the patient's concerns early, use plain language, avoid over-medicalizing, and keep the consultation patient-led, emotionally attuned and well-paced. And for Breaking Bad news stations, especially if you're in final year, this is definitely something that I would recommend to practice, and ideally have friends give you honest feedback. It's not just about following the spikes mnemonic, but you really need to make sure that you still take somewhat of a history and gather anything that you could be missing. Okay, for this one, my post-operative assessment of management, I believe it was a patient that had surgery and then they developed what I thought to be a STEMI. And yeah, I was able to do quite well on this one. I did pretty good in the domains. Initial approach to the patient could be better. Again, maybe if I introduce myself as a doctor, not a medical student. But the feedback from examiners mentioned about confidentiality and initial approach. Good combination of open and closed questions, covered most of the points about pain, reassuring to the patients, explaining future course of action, summarizing the points in the history, failed to touch on drug history or post-op mobility, good structured presentation outlining ECG abnormalities with MI diagnosis, mentioned management short and long term, had to remind for differential diagnosis. Yeah, but I think near the end, like when I was given the exam, at least the examiner told me to mention differentials. But after you've taken any sort of medical history, make sure to have your differentials ready, the investigations you want, and then the follow-up management. Really have that in, because like what I did, it's very easy to forget to say those things even though you know it, because this was just an acute coronary syndrome. So there's easy differentials, but obviously you want to save to get those marks, especially when you know the answer. It's really annoying to lose marks when you know the answer. I think for this one, again, I mentioned confidentiality. For final year stations, they really don't want you to mention confidentiality. So in your intro, don't say something like, you'll be speaking with me, but if I feel like there's any need to escalate to a senior, I may do that. For final year stations, I was saying that a lot, but in our feedback earlier, they told us not to say that unless you have a station where there's some issues with, let's say, confidentiality, and you feel like you may need to escalate this to a senior and break that patient's confidentiality. In that point, then it would make sense for you to say that you may need to escalate it to seniors. But initially, for intros, this isn't something that you necessarily have to do, and it's something that I would advise you to take out of your intro, because obviously I believe this lost me marks. I could have maybe gotten like a B or A for this one, but I got a C instead. But overall, I think this was a good station. Acute medicine assessment of management. This was a patient. What was it? Yes, a patient that came in with symptoms of an AKI, hyperkalemia. They had history of being on NSAIDs, which was most likely contributing to their AKI, and also have a history of cocaine. Overall, this was one of those stations where I thought I did well, but obviously looking back, I'm seeing that I didn't, especially in my initial approach to patients and information gathering. I would like to think that my history taking is good, but seeing this then, I really realized how bad my rapport was and how talking fast really has this impact. And it's funny because talking fast is a feedback that I've gotten from my friends, from the doctors I was at in my GP practice, but I still did it. So really make sure to slow down and focus not so much on trying to get all your information out, but really listening to the patients and seeing how you can help them there and then. The feedback was slow down, your intro was so fast it was hard to hear your name or the purpose of the consultation. I responded to patients' comments appropriately. Questioning was disorganized with no obvious structure. This makes it easier for you to miss important information. Practice. Did not mention ibuprofen as nephrotoxic. Did not explore renal symptoms. Or myalgia. Yes, of odor form, loin pain, rashes, arthralgia, myalgia. Very limited family history. Avoid jargon. Example, AKI, structured history, did not identify hypovolemia and ibuprofen as likely causes of AKI. No mention of renal imaging. Yeah, so this was just a really poor station. And it's one of those medical stations that the best way to improve, practice, find stations, OSCE stop, geeky medics, Pass Med even has some these days, and just practice, work on your pace, work on your structure. I really missed my structure in this one. They said that I had no structure is because obviously from what I said on my previous video, I'd like to ask questions there and then and not really follow a structure like what you see doctors do in the ward. But for OSCEs, follow a structure. If it's a chest pain history, start with Socrates, then move on to exploring conditions that it could be for your differentials, then doing a systems review, then looking at doing maybe either jump into your family history, past medical history, or doing ICE there and then. But follow that structure that you learn in first or second year of medical school. It helps the examiners mark you and helps you to not miss things. In real life, you can ask more specific, focused questions. But on OSCEs, open questions first, then move on to your closed questions. And this is a common theme that you'll see along these stations. And the feedback was here. I'm not sure if I should read it, but let me just kind of go through it. It says most students approach this case with structured, compassionate history and demonstrated good rapport with the patients. Higher performing candidates clearly explored urinary symptoms, fluid status, and the chronology of NSAID use in detail, identifying it as a likely contributor to the AKI. Some missed the opportunity to focus early on key renal symptoms, instead moved too quickly into results interpretation of broad systems review and management. Marks were often or most lost for failing to clearly prioritize the treatment of hyperkalemia, omitting key steps such as ECG or calcium gluconate, or not escalating early. Many students discuss fluid and stealth and nephrotoxic drugs, but did not always mention appropriate investigations such as urine analysis, renal imaging, or repeat bloods. Tailoring your plan to distinguish pre-renal, astringent, and post-renal causes, and showing clear clinical reasoning in how you would monitor, reassess, would enhance scores further. Okay, so this is definitely something that can be improved, and I hope this will helpful. Next one is inpatient assessment and management. Yeah, this was a patient that was actually a psych station. They were meant to have an Achilles surgery, but they were seen vomiting. On taking the history, they had bulimia. This one again, I just completely mucked it up by not having good rapport. I was not being as, I was speaking too fast again. The questions I was asking lacked no structure. Again, I was trying to do what doctors do and asking questions that I think of as they come up. But it's good to follow what the patient is saying, but still try and bring the patient back and take control of the consultation and go back to your history structure for those marks. So allow the patient's room to talk and to answer the questions, but also try and bring them back onto your agenda of answering the questions, of going through your Socrates, your systems review, etc. And that's where I really lost marks in domain 2 and domain 3. Management, bulimia, I think that was fine. Diagnosis was fine. Rapport and professionalism and the simulator patient mark, these are just both bad. I wasn't picking up on patient cues, I wasn't listening to them properly, and things like that. So let's look at this here. You introduce yourself clearly and check the patient. You asked open questions around the injury, but then asked a closed question about antibiotics, which confused the patient. I just did that because, now looking back, I know that was bad, but I just didn't want to miss it later, so I asked it then and then, but it broke the structure, it messed up my rapport because it just seems so outlandish. So definitely save questions on drugs for the drug history, just to look more slick. You asked about what her concerns were around the surgery, but could have asked more broadly. You asked about any medical causes for the injury and explored physical symptoms. There were a lot of closed questions and asked multiple questions in rapid succession. You did not pick up an appetite when the patient mentioned she felt she was eating too much, and you asked about this. You signposted that you might ask her more exploratory questions. You didn't pick up on her non-verbal discomfort around the questions, around explore further at times, example when she measured about loose stools, and continued on a very medical route of questioning. So this was a calm station. It was a psych station hidden in a medical station. So following down a medical route, of course, is necessary to screen out organic and psychological causes, but you still need to make sure that you're treating the patient as a whole, and you're listening to them, you're picking up on their cues, you're mirroring their tone, you're mirroring their body language to make them feel comfortable. You spoke very quickly at times and might be better to pace yourself much slower. You continued down a very medical route until the patient made declare she was feeling overwhelmed, and you asked about any support and asked about her mood and appeared concerned. You could ask more questions to explore this. When you did, it was more effective. You explored safe self-harm, and you did a psychiatric risk assessment around current suicidal at the end. The most likely diagnosis is bulimia, and you'd ask about other differentials on alcoholism. Baseline observations and get involvement of seniors, CPT, SSRI, and full exam, which I mentioned. You're professional and confident, but consider focusing less on the medical agenda and picking up on cues around verbal and non-verbal discomfort, exploring further. Apologies, I just expanded the case. Yeah, so there's a lot of feedback here, a lot of things that I should have done and I will do better. Definitely focus on comms, treat the patient as a whole, and look out for hidden psych stations. And here's the feedback from the overall. Students generally approach this sensitive consultation with warmth and empathy, and most correctly identified bulimia nervosa as the likely diagnosis. Stronger candidates structured the history around relevant eating patterns, purging behaviors, mood, and risk, and used both open and closed questions to explore these sensitively and thoroughly. Some students missed opportunities to ask focused questions about laxative use, physical consequences, or social context, while most included psychiatric referral in the management plan. Few clearly articulated the need for physical examination, ECG, and blood tests to assess electrolyte disturbance or dehydration. So make sure again to link the medical and the psychological when you're considering your management for these types of patients. Particularly importance given impending surgery. And marks were also lost when students listed investigations without explaining the relevance, or when they ran out of time discussing what they would have asked rather than what they would actually do. A clear structure distinguishing immediate physical care, risk assessments, and longer-term psych inputs would improve overall performance. This is something that's definitely improved and worked on for my follow-on stations and for my resit, but luckily psych stations didn't come up for resits, but it's definitely something at least now that you guys can focus on for your exams. Okay. So PEDS assessment and management. Yeah, PEDS histories, these ones are the ones I normally do good in for some reason. I do like pediatrics, I do like the histories, and I think once you've nailed the structure of a PEDS history, these can really work for you. If you guys want some more focused videos on PEDS histories, then let me know. But overall, we can just read my feedback for this one. You introduced yourself to Amber's dad in a polite manner. You asked of change to diet and appetite, food history, amount of food taken, asked of nausea, vomiting, change in color of stool, frequency of stool, asked of blood in stool, if stools float in water, changes the color of urine and dysuria, jaundice, itching and issues with joints and muscles, association of symptoms with triggers. He explores dad's expectations, antenatal scans, delivery and development milestones, asks about results of heel prick test, family history of celiac, hypothyroidism, medication and allergy history, involvement with social services, and smoking with family members. Manufacturer contacts and family. He explained the growth chart appropriately and recognized faltering weight on growth charts. You were able to summarize main symptoms obtained from the father in a succinct manner. Diagnosis includes celiac disease, cystic fibrosis infection. Explained to dad celiac disease, antibodies which attack gluten, which damages small bowel, leading to malabsorption and poor growth, and she needs to be on gluten foods and do a biopsy of small bowel, celiac serology, endomyosal serology, and then just a bit of the investigations I did. So yeah, this one was a classic bread and butter PEDS history, then investigations, differentials, and management, and it's something that will definitely come up on either a 4th year station or final year station. I'm sorry about my nose as well. Like, it's summer and I have crazy hay fever. Okay. Endocrinology examination of patient advice. Okay, yes, this was a endo exam, and they brought up a diabetic foot exam, which we've never really been taught before. We thought that it would be a thyroid exam, but our university likes to surprise us. So what do we have here? I thought the examination was good, but something else that I will say for a lot of these stations is make sure to read the brief. Because oftentimes I felt that in the stations I would answer the first brief, but I don't do the second. So let's say it's a station on perform a diabetic foot exam on this patient, then address their concerns. Because I see it as an exam station, I'll focus most of my attention and time on the exam, but then I rush the results. But for these stations, there'll be somewhat equal marks and equal weights for both sections. And just by doing well on one station, like the max that you could get would be 50-60%. You're still losing a lot of marks if you don't focus on the second part of what they've asked you to do. So that's something as well that I'd really advise you guys to do for your stations, for your histories. So I know this camera's a bit off-sided. Okay, so and what they're saying, it says good confidence intro, good inspection of all areas of feet and in between toes. Check the patient's pulses as well for monofilament. Checked on chest first before on feet, which was good. Checked vibration also, which was good. Checked reflexes. Reflexes also could have used chair to rest feet on for better examination. And finals could have mentioned fewer irrelevant negatives. Referral management could have mentioned annual fluid GP also. Didn't mention diet and lifestyle, but was slightly rushed at the end. Yes, so just better structure. I was rushed at the end trying to answer the second part, trying to explain the next steps. You know, if it's an exam that was 10 minutes, I could have done 5 minutes for the exam, 5 minutes for the explanation, really give my time, and it really allows you to have that rapport to speak with the patient clearly as well, which is something that I could have worked on. This is overall feedback. Students generally approach this station with a warm and patient-centered manner, showing professionalism throughout, most correctly identified the main examination components, but scores were often limited by lack of fluency, incomplete routines, or incorrect use of equipment, particularly the monofilaments. Best practice is to demonstrate the sensation on the sternum before testing the foot. The filament should be applied perpendicularly to the sole onto the bends, held briefly. Yeah, so when you're testing the filament, make sure to watch the videos online from Geeky showing you how to do a diabetic foot exam. You'll also see it in a lower neuro exam as well. So you should the filament should bend, held it briefly, but don't tap it or brush it when you're testing things like sensation. Many students waste their time by testing too many sites or using inconsistent technique. Common omissions include ankle reflexes, gait assessments, temperature checks, inspection between toes. A number of students also appeared unfamiliar with confidently eliciting reflexes or locating pedal pulses, suggesting limited practice. Management advice was generally sound but would be improved by specific discussion of glycemic control, lifestyle factors, and referrals to appropriate foot care services. More fluent, structured, and technical proficient examinations would improve scores significantly. Okay. Yeah, and that was that. Next one was neonatal assessment and differential diagnosis. This one I know I messed up. I was speaking too fast in this one. I got flustered with the investigations, and generally I'll just say I'm really messed up this one. There's nothing really else to say. So at least we have some comprehensive feedback. Your introduction was good. You confirmed the patient and dad's details. You explained why you were there. You don't need to worry about explaining confidentiality here. Yet you started with an open question and clarified further. You asked about stool and urine color, which is appropriate to the presented complaints. You didn't explore weight gain, which is very important. Yep, for history. It's weird because I did so good on the previous PEDS history, but I didn't do that well on this one. So still treat this as a PEDS station. But of course, patient rapport. You moved on to pregnancy history with signposting and moved naturally onto birth history. He mentioned the suction cup, which was the same as his daughter's birth. You asked about any ideas, and dad mentioned his daughter again. You could have asked more about her history. You asked about concerns, and he mentioned his uncle's history. You could have explored family history further here as prompted. And also, I was calling like the dad the wrong person or something. The dad mentioned like his family member had the same symptoms like his uncle, but I kept saying like something different, like his brother or his father. So, but again, that was just due to being flustered. But just practice mentioning, like making sure that you know who you're speaking to, and that you don't misquote what the patient is saying. If you do, apologize, take a deep breath, start again. You missed cues, and the dad had to say it was his uncle and not dad more than once. Yeah, so that's what I was saying there. You didn't seem to acknowledge the corrections. You seemed rushed at times, which I was. You quickly asked about medications. You noted raised bilirubin with normal conjugated bilirubin and LFCs. You said that jaundice started at 3 weeks. This was not correct, as dad stated 3 days. So just haphazard. I was saying the wrong things. I was missing up things. This does happen. If this happens to you, make sure to clear your mind before you move on to the next station. You said you're not thinking biliary atresia as low conjugated bilirubin, which would be correct, but that you were therefore thinking this was duodenal atresia due to weight dropping, which is not what the growth chart shows. This shows serial tracking on 25th centile. You said weight was tracking low, but it was not low. It was tracking as expected. You did not offer as physiological jaundice, breastfeeding jaundice as the main differentials. Yeah, so just an overall poor station. I would definitely just recommend, especially with these com station and explaining diagnoses, explaining investigations and management, to go into Geek and Medics and then just to practice those stages as much as you can, especially in earlier years. Just practice, and of course studying for the written exams will obviously help you with your knowledge here. But yeah, like, you can really just see what I've been saying before. It's pretty much the same problem that's just carried on through these stations, and it has here like the additional feedback as well to the cohorts. Finally, with a reassuring and patient-centered manner, most structured and neonatal history well, covering key domains such as feeding, stools, urine and birth history. Although some omitted medication, family and social history, a number of students missed action about birth weight despite its clear relevance. While most interpreted the blood results accurately, several gave overly broad differentials. Some inappropriately including biliary atresia despite normal conjugated bilirubin and reassuring stool color. High-scoring candidates correctly identified this as a case of prolonged unconjugated jaundice, most likely due to breast milk jaundice, and demonstrated clinical reasoning by excluding more serious causes based on history and investigations. Students can improve by tailoring the questions to neonate's developmental stage, avoiding, for example, queries about pain and mood, and by presenting their differentials systematically. Confidence in explaining why certain diagnoses are likely, rather than listing all possibilities, would also strengthen performance. Okay. So yeah, I hope that station there helps. Let's see how many more we have. Okay, let's do number 8. Yeah, this one was a pass. It was an inpatient safety incident assessment management. What I would say here is just make sure when you're I think I had to apologize to a patient because we gave her the wrong drug, so I had to make sure to take a history from her to see what had happened, to see if any harm was caused. Luckily no harm was caused. To explain what happened, take responsibility, apologize, and to let her know the next steps, which would be we would still be looking after her, would still make sure that nothing bad has happened. And if she still feels really upset, you can try and de-escalate and get the involvement of your senior. And you can also let her know that you do a day text, which would just be, you would write down what has happened. It would be sent off, to higher ups, and they track these things. So if over time, let's say over a year, these cases keep happening, they can see what they can put in on a system level to hopefully stop these types of problems or mishaps from happening again. So my feedback was appropriate introduction, but avoid speaking whilst reading candidate instructions during the consultation. Yeah, so I was reading back like my brief as I was speaking. So if you have to read a brief, maybe say something and then finish speaking, let the patient start speaking, then maybe look down, or look down while you're thinking, or even just let the examiner know, do you mind if I just have 10 seconds to collect my thoughts? A lot of my friends did that, and they said that they had good feedback and there was no problem with that. So appropriate intro, but avoid speaking whilst reading candidate instructions during the consultation. I asked about her background, her relevant history of high blood pressure and previous hospital admissions. I offered some appropriate responses to patient cues. I offered sincere apology, but I could pause and then reply to effectively answer patient questions. I asked relevant questions in regard to hearing. Mentioned to monitor the blood results in relation to kidney function, as well as explaining the completion of a DATEX, the management, ATE assessments, and relevant blood tests, assessment of hearing and kidney function going forward, urine outputs, as well as monitoring gentamicin levels. Yeah, I think the drug was gentamicin that she was given. No, I think actually I gave her, she was given the wrong dose of gentamicin, but no harm was caused. But it was still to explain back, to apologize. Thorough management explained, but could have improved fluency of delivery when presenting this in a structured manner. Yeah. So okay, definitely not the best, but we can see where we went wrong. Again, a lot of the same things are repeated, and then you can pause here. Since I passed this one, you can pause here to read through the feedback for the year. Okay. Obstetrics history, differential diagnosis management. Yeah, again here this one was good. Obstetrics, pediatrics, even on my resit, gynecology, all the specialties I seem to do quite well in. And again, all I would say is make sure that you know your histories inside and out. You know what to ask. You're asking about like their baby, you know, their inputs, how they're eating, what they're eating, how much they're eating, what they're eating has changed, their activity levels, their irritability, how much they're passing in terms of like the number of wet nappies, number of dry nappies, changes in color of stool, changes in colors of urine, go all the way back in time to their birth history, how they were born, when they were born, what method were they born by, did they have to stay in hospital after, what weights were they, how has their growth and development been, how has it been in line with the red book. There's so many questions. Again, I can go through a different video on a PEDS history, OBS history, gynecology history, because those seem to be histories that I do well in. If that's something that you'd like, please let me know and I can for sure make those videos. Okay, so let's just read back my feedback. Approached consented and relaxed in demeanor, consent focused and relevant with reassurance and confidence, explores symptoms for vision, bleeding, pain, movement, system inquiry, signposted for like bowels, palpitations, swelling, headache, urine explored, gestation, pregnancy history inquired, scans inquired, placental location, menstrual cycles, infection, smear, immunizations. Did allay patients' concerns, was able to refocus on history, family history, past medical history, drug history, social history done, communications, checks, ideas, worries. So you can even just see here, just before I keep going, I really focused on history for some reason for PEDS, OBS, and gynae. And I think that's just because I don't want to miss anything. But you see how just having a clear structure like boosts your marks like by like double. Like I would feel like for the most part I was the same person, but you can see how there's large fluctuations in my scores. So having a clear structure will just make you, even if you do bad, it will give you a solid score. I'm telling you, it will give you a solid score. Checks ideas and worries, explores concerns and empathy, organized with signposts and open and closed questions, diagnosis management, placenta previa, abruption, differentials, polyps, cervicitis, neoplasm can be offered. And then in terms of management, transvaginal ultrasound, CTG, senior review, C-section stated, can add BT, speculum, Kleihauer test, and rapport, sensitive, and engaging. Yeah, look, so the rapport, sensitive, and engaging. So I don't know what changed for this station, but I was happy there. And here's the feedback from the cohort if you want to read through that. Any other one here? Yes, MSK exam. This one, I think the two main reasons I failed this one: lack of structure. I started with special tests when I should have done the look, feel, move, and I did that because during my examinations, I would normally do special tests first just to make sure that I don't forget them. But obviously, when the examiner saw this, they must have seen this as me not knowing what I'm doing. So definitely follow the structure of however you've been taught exams at medical school. Look, feel, move, follow that structure, which will definitely help you. And the second thing was I didn't answer the second question. So I did the exam, but they also told me to spend some time as well to let the patient know what the next steps are, provide the appropriate investigations and management. And I got the wrong management here, which was really annoying because I know that deep down that, you know, completely lost my train of thought. But with what I was saying about with my management, I know I messed it up, and I actually knew what it was. There was only really two differentials. There was like adhesive capsulitis and a rotator cuff tear, and somehow I messed it up. But this can happen. Okay, so if you ever feel like you're rushed or pressured, calm down, take a few seconds. Those 10 seconds can do a lot for your mental health. It can do a lot for the way you are, for your nerves, and it can help you be more clear and gain those marks. Okay. Feedback. Clear introduction and explain examination before conducting. Asked about pain, inspection, palpation, one palpated structures. Remember to take time to assess each structure systematically. Could have examined the bicipital groove when stabilizing shoulder joints. Movement started with one specialist test and then moved on to active shoulder movements quickly. Examination could have been more fluent by following a more systematic approach. Able to elicit that the internal rotation was painful rather than external. Resisted movements were appropriately tested. Assessed function to conclude. Remember to differentiate between pain and weakness when doing resisted movements. Repeated some parts of the examination. Yeah, so I did some parts of the examination again, just to, because I think the person had a rotator cuff tear and they had a painful arc, so I did that again just to make it clear to the examiner what I'm doing. Maybe I should have told the examiner that, but I guess maybe from their point of view it looked like I didn't know what I was doing. So again, really make sure that you just look confident, you feel confident, and maybe even just say what you're doing. Like if you're doing it again, just say that you're doing it again, just to let the examiner know what you're thinking, that you know what you're doing, but you just want to be extra clear. Findings: identify the painful arc. Diagnosis stated as adhesive capsulitis, which was wrong. Differential rotator cuff pathology. Management offered some awarded investigations. Yeah, so also make sure when you're practicing, go through investigations, be really strict with you and your friends. Make sure that you guys only say the correct differentials, the correct investigations. Sorry, I'm saying make sure that when you guys give the correct investigations, make sure that is relevant and explain your reason why. Say that you're doing an x-ray because you want to look at the joints, or you're doing an FBC because you're worried about anemia, and you're looking for low red blood cells. Work on doing this early, because this will really play a factor in 4th year and 5th year. There's a massive jump in OSCEs then, when it's very easy just to lift stuff and ramble investigations, but it just doesn't look structured. Work on saying with your friends during your practice why you're saying certain investigations, why you're suggesting this. It just looks better and it gives you more confidence. It gives the examiner more confidence in you as well. So unwarranted investigations, i.e. blood tests such as ESR and CRP, because this wasn't a rheumatological cause, so there was no need to say this. I wasn't worried about inflammation because there was no pain in the joint, so why would I even say this? But again, it was nerves, it was speed, and it was lack of practice of saying the right things. As well as x-ray, rather than leading with conservative management like rest, lifestyle modification, appropriately offered NSAID use, mentioned as exercise in case it has diabetes, or for the shoulder joint pathology itself. Okay, and cohort feedback. This was generally a well-performed station, with most students demonstrating in a friendly and professional manner, clear explanations and organized examination approach. Stronger candidates expected from all sides, palpated systematically and assessed active, passive and resistant movements while isolating joints appropriately and clarifying where pain occurred. Lower scoring students were often omitted checking shoulder temperature before palpation, an improvement step in unilateral pain, or did not adequately test resisted internal and external rotation. Many missed the painful arc, particularly when movement was halted too early in response to discomfort. While most suggested rotator cuff pathology or impingement, some did not clearly distinguish between diagnoses or offered unnecessary imaging or referral. Higher scoring students gave well-reasoned management plans, including NSAIDs with specific details, physiotherapy, activity modification, and steroid injection if symptoms persisted. Practicing structured presentation of findings and justification of differential management would further enhance performance. So yeah, this is just what I was saying there about practicing, saying differentials, saying why, going through investigations and saying why, etc. We're nearing the end of this video. This has been such a long video. I hope for any of you that stayed here, leave an emoji of your biceps flexing or raising arms. Those emojis, just to show they've made it this far. Okay. Yes. Okay. So, acute medicine assessments, management, and handover. So yeah, this was a 10-minute station. It was a patient that came in with vomiting for a few days and illness, and it seemed like they were having something like either a DKA or a HHS, which is hyperosmolar hypoglycemic state. Excuse me. And yeah, it was just a classic history, differentials, management, and then a handover. So I had to hand over to a doctor that was there. This was new because I think I didn't really work too much on handovers. I worked on handovers because I expected an ATE exam, but not a handover after a history. So there was no actual ATE exam on our final year OSCE, even on the resit, which was surprising. But that was something I really worked on myself. Normally ATE, just pure medicine, is something that I do like to think I do well in. Despite what you've seen so far in this video, I do like to think I do well in on my practice. But yeah, this one, just structure, So let's see what it said here. History taken, good history taken, was maybe try more open-ended questions. Yep, that was definitely something that I improved on. Start with more open-ended questions first before moving on to closed questions. Rather than running through the systems review, allow patients to allay his concerns. Maybe not use terms like autoimmune. Yep, they use jargon. Unless it's to the examiner. Manage a quick history of PMH, of pathological history, social history, family history, medication, drug history. Handover could use terms like polyuria, polydipsia. Yeah, so when you're handing over, use the key jargon there because it just speeds up time. And instead of saying like he's thirsty, he's urinating a lot, polyuria, polydipsia, better concise summary of history, interpretation of results, pick up positive points. Did mention that he was worried about this patient, DKA, HHS management, further examination investigations, IV infusion, IV fluids, regular monitoring of glucose, and could mention it could drop once insulin infusion. Gave summary at the end of handover as well. I mentioned about need for HDU ICU. Yeah, so yeah, seems like the cohort generally did well. The stations did well. I got in the explanation, information given, did quite well overall. Information gathering could have been better if I just had a better structure. So you see how much structure using open questions, just the basics of medical history taking can really impact your score even in final year. As much as you think it doesn't, really make sure that your structure is locked in. It's something that I would even say and recommend for any student. So even if you're doing histories in 4th year, final year, 3rd year, go back and just go through the anatomy of a history that you've learned in 1st year, 2nd year. And you can read the feedback here. From the cohorts. And the last station, which is definitely the worst station, I don't think I've ever gotten a score this low on any of my previous stations. Okay, let me zoom out first. Okay, I don't know what's going on. Okay. Discussing a medical procedure. This one was where I had to explain an NG tube to a patient that's had learning difficulties. The patient, she was oftentimes, ask you questions that seem to be sort of, weird or different. And she also did not look at you, and you really had to make sure to explain things well. Me personally, this was one station that I was also very, very shocked at. I thought that I did well, but looking back, of course I didn't, and I also really got not much feedback. Considering I got 20%, you would think there'd be a lot to say for what I did wrong, but yeah, I didn't get much feedback. But let's read it. Polite intro, but made a statement about confidentiality. Yeah, so don't make that statement about confidentiality in every station like I did. Only leave it when you actually feel there's a need to escalate or to break confidentiality. If you're feeling like a child lacks competence or she's at risk of harming and you need to escalate, or if you're worried about domestic violence in like a woman and she has dependents at the home that need help, like children that could be at risk, then you mention it. But obviously you can see in some cases it really just messes up your score for the initial approach. In some stations, they'll maybe let you off and give you a C or a B, but obviously in this case I got D, which was only 3% of people got it. So it says, so obviously this sounded unnatural and not relevant to this patient, and I think I was even marked worse because obviously this is a patient that has learning difficulties, and saying that thing maybe might have made them a lot more anxious or nervous, and just not what you really need when rapport is the key thing in this station. Like you see right here, like my score for rapport is 4%. I got a D for that. Okay, so history taken, but also strong, but there's a string of closed questions, rapport lacking, so again, lack of structure. Moving on to closed questions, when I could have explored more with open questions, which again just goes back to the basics of like a history. Open questions first, then closed questions. Rapport lacking, explanation of Crohn's was too elaborate and not simple enough for this learning difficulties patients, and I asked the patient to repeat back, so I got some understanding from the patient. But yeah, overall, I should have explained more. I should have given the patients, more time. I should have focused more on my communication, answering your questions. And again, I think I've spent too much time trying to explain the NG tube. But another part that I missed was They also want you to address the patient's concerns. So again, with these stations, they really tell you what they want in the brief. They didn't ask me to take a history. Of course, still take a history, even if it's brief, in every station. But they asked me to explain an NG tube and to address the patient's concerns. And I really only spent time focusing on explaining the NG tube. Even if I did well there, that would only be a maximum of maybe 50%. But another section is still, like the other half was to address the concerns, which would be another 50%, you know? And I'm missing out key marks there because I'm spending too much time on the NG tube, you know, trying to explain it. I would go down, you know, their nose, and I was using the example that they had there of the NG tube in the station. You know, but these things together, you know, you really need to make sure to hit both of these points. And the only way I can give you advice with this is to practice. Okay? Let's look at the feedback from the cohort. This was generally a well-performed station, obviously not for me. With most students adopting a warm and patient-centered approach, using clear language and demonstrating empathy, stronger candidates explored the patient's understanding and concerns, explained the purpose and process of NG tube insertion clearly, and acknowledged her learning and disability in a sensitive and practical way. However, many students miss key aspects of history, including the nature of her learning and disability, her social support, and relevant details about her Crohn's disease, or asked narrowly focused symptom questions without tailoring their language. Okay? Yeah, again, rapport, jargon, especially for patients that have learning difficulties, is very key to make sure that you get this right, in order to make sure that you're patient focused. The patient feels comfortable explaining to you whatever problem they have. And also just to make sure that, you know, you can make them feel comfortable as well, because obviously they're in there, they're nervous, her mom was in there, so you want to make sure that your patients are as comfortable as possible. While most explained risks and benefits of tube feeding, fewer addressed practical concerns such as mobilization. So again, addressing concerns. This was another point that they wanted me to work on, to address the concerns, and which was the second point of my brief, but I don't think I spent as much time doing that. I spent a lot of time on trying to explain the NG tube, and then, you know, rush this near the end. Washing medication use, offered alternatives to tube feeding. High performing candidates priced information appropriately, use visual aids or props, and offer to involve the patient's mother in future discussions. To improve, students should practice adapting both content and communication style to the patient's needs while supporting informed, shared decision making. Okay, a lot of feedback here that we can do. Overall, I think rapport, structure, initial approach to patients, information gathering, just the basics of a history can really just drop your marks. Even before you get until actually answering the question, rapport, structure, all of these things can really just affect your overall marks, especially in final year, where like they're really testing if you're really able to go and work on a ward and go and see real life patients, you know, where there'll be no examiner watching you. But I hope that this was giving you guys a key, you know, just a really look into how this final year OSCE was. This was the first one that I failed, and in the next video I'll go through my feedback from my resit, and you can hopefully see how there was some improvements. Of course, there was still like two stations that I failed, but my lower score there was like 49, whereas over here it's like 20. So you can obviously see that there's been a massive improvement, and I think the main improvement that I had, of course, knowledge is essential, but there was people that passed the OSCE that failed the UKMLA, like the written multiple choice exam. So you don't even need as much knowledge as you think to pass these exams. Honestly, I think a large part of OSCEs is just aura. You know, like you just need to be able to feel confident in what you're saying, know your structure, keep your structure, listen to the patient, pick up on patient cues, go back to your structure, signpost, you know, just basic things that you learn in first or second year. Keeping that all the way through will really help you to at least have a good foundation of scoring the easy marks, the, you know, initial approach to patients, information gathering, information taking, rapport and professionalism, scoring all these easy marks, which you can definitely score before you even get onto finding the differential and the investigations, the management, which you'll most likely know for most stations just based off you studying for the SBA exam. But all of these ones are marks that you guys can definitely get. But yeah, I really hope that this video was somewhat helpful for any of you that watched it. And yeah, you know, if you want me to make the follow-up video based on this one, then please like this video. Let me know what you enjoyed in the comments below. Let me know how I can make these videos better. And I'll see you in the next video.